This is a routine mature cataract and a probably mid-dilated pupil, and I am going to just demonstrate how I went about doing a phaco in such a case. Slightly intumescent, but not that much of a cause to worry. So after performing my incisions and staining the capsule and expelling both the air bubble and the stain with 2% HPMC, I go ahead and fashion my capsular excess, almost let go, and look at the mistake I have done there. Look at that forceps. That is not a good forceps. Look at those teeth of those forceps. It's not exactly holding on too well, and I still haven't noticed it. Somehow managing to have some hold, and lucky me, the forceps held on and I was able to complete the rexes without any more further waste of time. And that's it. And then I do mild hydrodissection. Most of the time it's not necessary to do a hydrodissection in these cases. And try to rotate the nucleus with the tip of my hydrodissection cannula. Didn't happen. So, but I'm sure it is hydrodissected. I could see it, the forward movement. I take a sharp chop in my left hand, my phaco in the right, and proceed to go ahead and do my direct vertical chops. And that's easily done. Pupil is also holding out well. Nothing much to worry. This sort of pupil is more than enough to complete your phaco, especially when you have choppable cataracts. If this cataract was very soft, I would consider using an expansion device. But I think I can manage in this case. I already got one piece, and make sure I get another. I want at least 4 segments in a case like this. And that's done. So just I decide to remove these segments by a one-handed technique rather than pushing in the chopper from the side port. Remains to be seen whether it can be done. Yeah, I suppose it can be, but I just got to chop this a bit. So go in again. Make sure you bring the nucleus back to the center of the pupil. Go to the iris to the level of the iris, and then only chop. Don't start eating somewhere over the iris or at the pupillary margin, because that would engage the pupil. So now that all the pieces are out, the cortex can be a little bit problematic because the pupil is more or less shut down. However, I seem to be able to manage. There is some cortex there. You got to sweep off the iris from interference and get at the underlying cortex. These maneuvers can be tricky in the sense sometimes this posterior capsule can be tented up, and if by chance I turn my port posteriorly, it's very easy for me to catch the posterior capsule. So going in a methodical way to make sure that all the cortex is out, and then under hydroimplantation implant this single piece hydrophilic IOL directly into the bag. And there, that's easily done. Once that's over, put in my intracameral antibiotic, go ahead, hydrate the wounds, and conclude my surgery. Thank you so much for watching.